Good morning, everyone. I'm Dana Corson, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us this morning for a webinar on the report that was just released titled Finding a Path to Safety in Food Allergy, Assessment of the Global Burden, Causes, Prevention, Management, and Public Policy. You can now download a copy of the report and other supporting materials at www.nationalacademies.org/food allergies. And you can follow the conversation about the report on Twitter at #NASEM For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The academies operate under a congressional charter to the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report's findings and recommendations. But before I introduce the committee, I want to go over a few technical reminders. So after the opening remarks, we will begin to take questions through the Q&A box located in the lower right-hand corner of your screen. Simply type your question into that box at any time and click Submit. We ask that you leave the box set to send your questions to all panelists and that you identify yourself and your organization when asking a question. If you have any technical issues during this webinar, please contact WebEx Technical Support, and here's that phone number. It's 1-866-229-3239. Now, I'd like to introduce the members of the committee who are here with us today. First, we have our committee chair, Dr. Virginia Stallings. She's professor of pediatrics and she's the director of the Nutrition Center at the Children's Hospital of Philadelphia. She's our expert on pediatric nutrition. Next, we have Dr. Hugh Sampson. He is professor of pediatrics and director of the Jaffe Food Allergy Institute at the Icahn School of Medicine at Mount Sinai in New York City. And he is our allergy expert. Next, we have Dr. Ana Maria Ciega-Rees. She is professor of Public Health Sciences and Obstetrics and Gynecology at the Department of Public Health Sciences at the University of Virginia in Charlottesville. And she is our nutrition expert. And finally, we have Dr. Stephen Taylor. He is co-director of the Food Allergy Research and Resource Program at the University of Nebraska-Lincoln, and he is our food science and safety expert. So we'll start off with a presentation summarizing the report by Dr. Stallings, and then we'll open it up to any questions you may have. Please note that this briefing is scheduled to last about an hour unless we run out of questions beforehand. And with that, I will turn it over to Dr. Stallings.
Good morning, everyone, and again, welcome to our report release. The work I'll be presenting is from about the last 18 months and by really an extraordinary committee who worked over this period of time. When you start a study, one of the first things from the planners and the sponsors is to create what the priority areas are. And this is really quite a broad report. So I wanted to give you in broad strokes why why a study was commissioned on food allergy. So there were a number of knowledge gaps that were identified, particularly the lack of information on prevalence of food allergy in the U.S. and the ongoing question about, is it increasing? Next, there's a question about what is the best way to diagnose food allergy in the modern healthcare setting? Are there ways to prevent food allergy or decrease the risk for prevention of food allergy? And lastly, what kind of management approaches could we take, considering all sorts of settings, including the healthcare setting, but also food industry and individuals and many others? The sponsors of our study included federal sponsors and non-federal sponsors, and all of them are shown here. And the process, as you've heard a little bit, is one of defining a study. And just to mention, the work on that began in 2012. So the process of creating the team to do this work and the deliberations has gone on for quite a while. And also to mention that the communication and really dissemination strategies are something that the academies are considering, but also the sponsors are as well. In our setting, one of the most important things is the statement of tasks for the committee, and this directs us as to what are the things that we are obligated to review. And for the purposes of this presentation, I wanted just to bring these together as two big concepts. So the first is our job was to bring together leading investigators from the relevant scientific fields, the clinicians with the most experience, and also parents, and to develop a framework that would allow us to address the work that needs to be done in the future. And the second part of our task was to make specific recommendations to be implemented by both government and non-government agencies. So one of the first tasks that we did have was to find what was going to be in our scope of work. So what is a food allergy? Here I am presenting a highly accepted definition. Food allergy is something that has adverse health effects arising from a specific immune response that occurs reproducibly on exposure to a given food. And in the context of our report, we definitely focused on the IgE-mediated food allergy. And here you see some of the common characteristics of an IgA food allergy that really help distinguish it from some of the other common food reactions or intolerances. So to reiterate, food allergy has immediate to very fast, maybe up to 2 hours onset of the clinical reaction. It can require a very small amount of the food allergen for the reaction to be initiated. And the typical symptoms involve the skin and the respiratory system and the GI tract. So often people are aware of urticaria, or called hives, angioedema with the swelling of the hands and the lips, and vomiting and diarrhea as common GI symptoms. The most critical symptom is that of food allergy-induced anaphylaxis. So to address this task, we also wanted to acknowledge the complex environment that a patient or an individual with a food allergy lives. And using this schematic, which is an ecological developmental model or a framework, we use this to step forward into dividing up our different reviews of literature and to think about recommendations that would go to each component of this complex model. The individual, of course, is at the center of this and is constantly exposed to food allergens in that we all eat 3 or 4 or 5 times a day, lots of individual decisions, but also to fully acknowledge the importance of the family and home, and for children, the child care and school settings, for adults, the work settings, and the relationship with the healthcare providers. Then in the 2 other circles you see, we know all of this takes place in community. And we also know, using the outer circle, the importance of partnering with the food industry and other industries, because those practices have an impact, and also the government, the opportunity for government to consider policy and regulation. Lastly, we all acknowledge that food and eating has a significant cultural and societal impact. So we, by establishing this framework, allowed ourselves to look at any number of components that had been recommended by our sponsors and advisors. This is the other major figure, I think, in the report, and this is our roadmap to safety. And as you look at this, you'll see that there really are, we've summarized it into 6 different action areas shown on the left. And then we have icons for the various actors that are involved. And you can see that that includes the research community, government, healthcare, industry, our public health authorities, many professional organizations, and many educational institutions. And for each of these ideas of what we want to be addressed, there are different groups that are going to have an opportunity to work towards this. By the end, we were able to summarize our major goals into those that are short-term, and you see this on the right, where out of all of this work and this collection of quite a number of recommendations, the primary short-term goal is to decrease the number of severe food allergy reactions, and next to improve the quality of health as well as the general health of people with food allergy. And lastly, for short-term goals, to increase awareness and to dispel the many misconceptions about food allergy among all of the stakeholders. Long-term, of course, we all would like the scientific and clinical communities to continue to work so that we can develop safe and effective therapy for food allergy. And the ultimate goal is to be able to prevent food allergy from occurring at all. So the rest of my remarks will go through highlighting a number of the recommendations. This is a big report, and there really are a number of detailed recommendations, and I urge you to read the report and find the section that relates most to your interest and your opportunity to help with this. But I'm not reporting all of the recommendations, but the issue of prevalence became something the committee was very aware of and was one of the major task statement requirements. And after reviewing all the literature, it's very clear that in the U.S. we do not have great prevalence data. And I just use this figure as an example of some of the limited data that we have that might suggest the prevalence is on the increase. But as we reviewed the literature, there is insufficient data to talk about what % of the U.S. population has food allergy, what those food allergies might be. But here you see a graph showing hospital discharges in children that were directly related to a food allergy health event. And even in the short course of 1998 to 2006, you see about a 4-time increase in discharges related to food allergy. Again, just an example of the kind of data that we might have. With this review, the committee recommended that the CDC obtain a prevalence estimate on food allergy in a very systematic and statistically sound manner. And to design a study like this, there's some key elements. One of the main ones is to have a sufficiently large population for the study, a large sample size, and that it includes sufficient numbers of children and adults so that we can have prevalence data by age, because it does differ across the life cycle. In addition, the committee calls for the new study to be sufficiently large that we may have statistically meaningful results looking at different subgroups, such as those by race or ethnicity or by socioeconomic status, because being able to determine the prevalence and the differences in diagnostic rates in these groups will be fundamental information needed to make good public health and healthcare policy. The next overriding issue that we considered was that of diagnosis and prognosis. And after reviewing an extensive body of literature, the committee recommends that physicians use evidence-based, standardized procedures as the basis for food allergy diagnosis, and to avoid those non-standard and unproven procedures. In addition, when a food allergy is suspected, that a patient should be evaluated by a physician who has the necessary training and experience to both select the right test and to evaluate the history and physical examination, and then to interpret those diagnostic tests to be able to decide if an individual patient does or does not have a food allergy. The issue of prevention, of course, is of interest to all of the stakeholders. And as the committee did this work, we found that there really is quite a long list of things that have been proposed as possible ways of preventing food allergy. And we clustered these under those that were prenatal characteristics, which then of course means this is what the mother could be doing in thinking about prevention of food allergy in their offspring. What happens in the newborn infant near birth and over those first few days and months of life, considered the perinatal period, and postnatal opportunities as you have a child grow up through school age. And what I would like to say for this is, one, there'll be a very nice review of literature for all of these things in the report, but none of these rise to the quality and body of evidence that's sufficient to make them as real recommendations for clinical care or for advice to parents. So that none of these potential ideas have reached the kind of scientific integrity that means they should be moved forward. That's not to say that many of these will continue to go under very rigorous scientific experimentation and clinical studies and trials, and that data will obviously be in the future and be able to be considered. The major prevention recommendation that has come out in really recent history is related to some studies that were completed over the last few years. And that's captured in this recommendation, where the committee recommends that the public health authorities and the clinical practice guidelines include clear, consistent, and evidence-based advice for families and healthcare providers, including dietitians, about the potential benefits of introducing allergenic foods in the first year of life. And again, I encourage you to go read the section of the report that addresses this. The lead studies and the lead allergen in this body of work was the peanut and the peanut allergy. There are other studies that are ongoing now for other common allergens in children, like milk protein or egg. But at this point, this would be the recommendation, and we encourage all the authorities that make clinical recommendations to get together and be able to give the consistent, clear advice. The committee, as directed by the task statement, spent a good bit of time thinking about education gaps and the need for training. As you see on this slide now, there's a header that includes many of our stakeholders, the public health authorities, healthcare providers, patients, and their caregivers. So there is, again, the opportunity for work to be done in almost every sector. Here, the committee recommends that the CDC work with other public health authorities to plan and initiate a public health campaign that will increase awareness and empathy, as well as to dispel misconceptions about food allergy. The next related recommendation is that we recommend to public health authorities that they regularly update guidelines on both diagnosis, prevention, and management of food allergy, because the committee suggests that we're in an era where there will be significant new data coming out over the next few years. And we would like for the system of recommendations to be very nimble and to be able to respond to the new body of evidence. Again, for the group, the committee recommends that healthcare providers counsel patients and their caregivers on food allergy following the most recent and accurate guidelines, and also emphasizing the need to take age-appropriate responsibility for managing food allergy. And this is particularly as you think of children going through adolescence and becoming more independent. The issue of counseling was, again, something that the committee considered a good deal. So here in the first bullet, you see recommendations to the healthcare providers for general practice. In this exercise, we also established that there are some very high-risk groups where the idea of counseling would be particularly important because the risk of food allergy and, in fact, the risk of severe food allergy reactions is highest. This is really two groups, thinking of the adolescent young adult who we know have more risk-taking behavior. And another group that may not be so well appreciated is those patients who have both food allergy and asthma are at particular risk for having more severe reactions when they do have a food allergy experience. So again, counseling has two different purposes here, one general and one to rapidly conduct counseling with the higher risk group. In the committee's deliberation, it became apparent that there was some inconsistencies in the use of emergency epinephrine. And so the committee recommends that healthcare providers and others, which would include first aid responders, use intramuscular epinephrine in all infants, children, and adults as the first line of emergency management for episodes of food allergy anaphylaxis. In addition, in evaluating this emergency care setting, the committee recognized that we need a lower dose epinephrine syringe or dose. So here the recommendation is the Food and Drug Administration evaluate the need, and if they too find it's indicated, that they guide industry to develop an auto-injector with a dose of 0.075 milligrams of epinephrine per dose per administration that's specifically designed for use in infants who have a lower body weight. Along the lines of, again, education and training, it was established that you have a lot to learn in medical school, but that we need to increase the curriculum content for medical schools, residencies, and fellowship programs, and other relevant schools, training other healthcare providers, so that there is clear understanding of the management of food allergy and food allergy anaphylaxis, and that the idea of the importance of counseling patients and their caregivers be understood by care providers across the spectrum. In specific for first responders and first aid personnel, the committee recommends that groups such as the American Red Cross or the National Safety Council provide emergency training to the general public and to first responders and to first aid personnel across various professions and in the workplace, and to be sure that food allergy and anaphylaxis management is in their curriculum. Specifically for food industry personnel, The committee recommends that the food industry leadership provide the necessary resources for integrating food allergy training into their various existing general food safety programs and their customer service training for employees at all levels and stages of the food industry, which, as you can understand, would go from food manufacturing all the way to service in restaurants. So the next broad issue that we attacked could be summarized by thinking about policies and prevention strategies of severe reactions. Again, the committee's task was to find a way to make the whole environment safer for patients with food allergy. So, related to the labeling of packaged foods, the committee recommends that the Codex Alimentarius Commission and public health authorities in each individual country decide on a periodic basis about which allergenic foods should be included in their priority list based on specific scientific and clinical evidence that is regionally or nationally based on prevalence and the severity of food allergy, as well as the allergen potency. The committee also recommends that the Food and Drug Administration make decisions about labeling exemptions for ingredients on the current food labels derived from a priority allergenic source, and that this be based on a new quantitative risk assessment framework. And that food manufacturing industry, the FDA, the USDA, work cooperatively to replace what's called a precautionary allergen labeling system, which is there to identify potential low-level allergen contaminants, and to replace this system, the precautionary allergen labeling system, with a new system that is risk-based. And the committee calls out the example of the VITAL program that's used in Australia and New Zealand. The committee also, in its deliberation, became aware that there is already a 2013 Food and Drug Administration Food Code. And with this, the committee recommends that all state, local, and tribal governments adopt this approach with this food code, which already includes provisions for food establishments on the prevention of food allergy. At this point, some states have adopted this approach, but not all states. So then, thinking of the other important settings for patients and their families with school allergy, certainly schools, early daycare, educational facilities from kindergarten through university, and airlines are all specific settings that the committee considered the need for changes that might enhance safety. The committee recommends that relevant federal agencies convene a special task force to establish and implement policy guidelines in three areas here. One is to assure that emergency epinephrine capabilities are in place in public venues. Next, to provide standardized food allergy and anaphylaxis first aid training to appropriate staff in these settings. And lastly, to be sure that we implement education standards for responding and managing to food allergy emergencies in these settings. And again, all of this will have pages of text explaining the literature and the current conditions. Related to this, the other call is for the FDA to continue to work with other relevant agencies to develop and implement labeling policies specific to allergenic ingredients that are in packaged and prepared food, such as those that are distributed through airlines or other public venues, including schools, early child care, and educational facilities. As you might imagine, after going through this work, we have a whole list of research priorities. Each of those are listed and integrated into the chapter that covers that body of work. In addition, at the end of the book, Chapter 9 brings all of the research recommendations together, and so that's another place where you could look at that. But for this report, I am not going to detail any of the specific research priorities. I would certainly like to recognize and commend the extraordinary people who've spent a great deal of time volunteering on this project, and all of which brought a unique experience, both scientific and clinical, to the table. In addition, to acknowledge the incredible support from our study staff, and to recognize that this report committee was a combination of inspiration from the Board on Children, Youth, and Families, and also from the Food and Nutrition Board. And we're very thankful to all of the individuals who have helped us with this. So as you heard at the beginning, as of now, the report is released. You can go to this site and get all of the information that you need. And just to say, the report is there. In addition, the press release is there. I find a very useful 4-page document that is called the report brief is available for your download. And in addition, at the slides that I used today in this presentation will also be posted. So with that, I'll end the formal part of the presentation. And as you heard at the beginning, the question and answer session will be moderated by my colleague Dana, who is here. And that, you recall, we have 4 of the committee members available for commentary. Thank you.
Thanks, Dr. Stallings. So we'll now open it up to questions. Just a reminder, please identify yourself and your organization when asking a question. So just to get us started off, can you tell us a little bit more about the gap in prevalence data in the U.S.? What are the next steps?
Thank you. This is Dr. Stallings. Actually, I'd like to refer that to Dr. Sampson. I think he would be able to make some comments. Hugh, will you take that one?
Sure. Thank you. I think one of the realizations as we went through all the data, looked at the various meta-analyses about prevalence of food allergy even around the world, it was clear that we have no real good prevalence data in the United States. That conducting these studies are quite expensive, they're also quite difficult, and to this point in time it has not really taken place in the U.S. We really felt that an accurate assessment of the true prevalence of food allergy was a real major need for the country, because this helps us prioritize food allergy as a public health problem. It also helps direct appropriate resources towards the problem, and also really helps us assess the risk of various food allergic reactions in different populations. And the committee has made some recommendations whereby certain agencies such as the CDC could take advantage of the NHANES data or the NHANES studies that happen on a regular basis, including the appropriate information, and then including certain allergy tests as well as oral food challenges, which are often necessary to really confirm the presence of food allergy. I think everyone on the committee truly felt that food allergy has been increasing in prevalence over the last decade or two. But again, we have no really good studies to support that. Unfortunately, 2 decades ago, without these studies having been performed, it's going to be difficult to look at a baseline. But as I said, I think most people feel fairly confident that this is an increasing problem. The numbers that are given out now as far as prevalence of food allergy in the U.S. ranges from about 12 to 15 million Americans, which certainly indicate that this is a very major health problem in the country.
Thank you. Do we have another question?
Yes, this question comes from Rachel Ehrenberg at Science News. Rachel asks, should we, parentheses, the public, scientists, healthcare providers, stop calling things like lactose intolerance a food allergy, the non-IgE mediated allergies?
That's a very good question, and I think both the committee and the general medical community would agree that differentiating these is very important because the treatments are different, the health risks are different, and it's very important for a patient and a family to know if something is an intolerance, which is an important clinical condition. But an intolerance to lactose is the milk sugar, or an intolerance to wheat with something like celiac disease. Those are very important diagnoses that also have good treatment strategies. However, they're very different from food allergy, which in many ways is harder to diagnose, but also has a very different level of severity, which includes risk of death from anaphylaxis. So I do believe that the committee's goal in the public education process is to help us sort that out and to understand the differences and implications of a food allergy versus a food intolerance.
Thank you for that. We have another question. This comes from Tracy Bush. Tracy says, asks, please explain what the committee considers a non-standardized procedure in testing for diagnosis. Does this include food allergy intolerance testing?
Thank you for that question. And again, Hugh, I'd like for you to address that and discuss some of the things that represent concerns about different kinds of diagnostic testing.
Sure. Thank you. So basically at this time, there are two what we would consider laboratory type tests that have been validated to have some value in the diagnosis of food allergy. One is the prick skin test, whereby a small amount of the food allergen is placed on the skin, a slight prick in the skin is made, which allows the food extract to get near the mast cells, causing a small hive at the site if a person has evidence of IgE antibody to that particular food. So what this test does, however, is it tells us the person has the IgE antibody. It does not mean that that person would then react to the food. The other test that's done is looking at the actual IgE or allergic antibody level to a specific food in the blood of the patient. And again, evidence of IgE antibody in the blood does not necessarily mean that a person will have a reaction to that particular food. The part where you need some healthcare practitioner who understands the use of these various tests is that we know with the skin test, for example, the larger the hive or the wheal that occurs with that skin test, the more likely it is that that patient will have a reaction to the food you tested. With the serum IgE level, the higher that level of IgE antibody, again, the more likely it is that that person will react to the food. However, neither test really tells you the type of reaction or the severity of reaction that a patient might have. The only test that allows us to test with near certainty that someone is food allergic is the oral food challenge. There are a whole variety of other tests that people do that have not been validated, things such as looking at IgG levels to a particular food is sometimes interpreted as being intolerance, but in essence, everyone makes IgG antibody to food, so it doesn't specifically indicate any kind of pathologic condition. And then there are a whole variety of other tests that are listed in the document that are sometimes used and are not confirmed. When we look at things such as intolerance, like lactose intolerance, There are specific ways to make those diagnoses, such as with breath hydrogen tests, but these are things that are not really part of the focus of this report.
Thank you for that summary. Dana?
Yep, we have another question. This comes from Dan Okenu. He is at HEB Grocery Company in San Antonio. He asks, could you elaborate more on the risk-based labeling system for food allergens versus precautionary allergen labeling system for low-level allergen contaminants?
Thank you for that question. I'll ask Dr. Taylor to address that.
Yeah, this is Steve Taylor from the University of Nebraska. The precautionary allergen labeling system currently is voluntary. It's not mandated by federal regulation. Since it's voluntary, it only has to pass very minimal standards in regulation. The statements have to be truthful and not misleading, which we recognize as a committee was a fairly low bar for the use of this labeling. The clinical and scientific literature clearly show that precautionary allergen labeling is used very widely within various food companies on packaged food products, and that the labels as they currently exist bear almost no correlation with the risks that those products might present to consumers, which leaves the consumers in a real quandary about how to interpret these labels and concerns about diminished quality of life because their diets are so restricted, leading many of these consumers to ignore precautionary allergen labeling in some cases. That's all documented in the published studies that we reviewed as part of this process. So our recommendation is that since food companies are really not well suited to develop risk levels, deciding how much is too much, that the regulatory authorities should consider adopting a more risk-based strategy for precautionary allergen labeling so that consumers would understand very clearly, obviously with some education at their level, what these precautionary allergen labeling statements mean and be able to make better decisions about which products that are safe to consume.
Thank you for that summary of a fairly complex set of ideas. Shall we go to a next question?
Sure. We've gotten a few questions about prevention techniques, so I wanted to address those. So what food allergy prevention techniques are effective for pregnant women or infants?
Thank you for that. I'll ask Anna Maria to take that, if you will.
Great. Thank you. This is Anna Maria Sigurich from the University of Virginia. So as our literature review that we conducted pretty extensively, because if you think about the life course perspective, we think about allergies potentially developing in the prenatal period. The evidence basically shows that there is no reason for pregnant women or women who are lactating to go on any kind of elimination diets. And in fact, the large randomized trials that are now the studies are being published and are in the works, are basically showing us that our guidance in the past of delaying the introduction of allergenic foods is not necessarily beneficial, especially even for those children who might be at high risk if they come from a family who has previous allergies. So in fact, the recommendation that is being made right now is no elimination diets for pregnant women or lactating women, and to go ahead and introduce potentially allergic foods. Potentially allergic, you could be allergic to any food is one of the things that we actually learned through the work on this committee, starting very early. So, and what we would recommend is what the WHO recommendation is basically saying is to breastfeed, but to introduce foods between the ages of 4 to 6 months of age when a child is developmentally ready.
Thank you for that. Next question?
Yep, next question comes from Lauren Deveni. Lauren says, you mentioned that it is important for child care providers to administer food allergy and anaphylaxis first aid training to their staff. Does this formal first aid training exist? Where can we find that? Similar to this, I wanted to, we got some questions about what should school nurses be doing differently in terms of food allergy safety.
Good. Thank you for picking up on all of that. And as you hear that considering safety in all different settings was one of the things the committee was very interested in. I think I'll ask Hugh again, because he's more on the front line in dealing with schools and what regulations may be in place. And then if Anna Marie wants to follow up on comments, we did learn that there are a number of sets of recommendations and regulations that are in place that we might be played on. But if both of you would talk a little bit about what the committee's recommendations are and what the result might be for safety in these settings.
Okay, so this is Hugh Sampson from the Icahn School of Medicine in New York. One of the things I think that the committee felt was quite necessary related to this was for certain agencies such as the Red Cross, who have various courses that they teach for various emergency situations, make sure they include training on the recognition and treatment of food allergic reactions. Right now, I'm not aware of any uniform programs that are out there. There are various food-related organizations that do have a variety of guidelines that can be found online, such as with the Food Allergy Research and Education Group, have many of these documents on their website. However, the committee really felt it was important that various governmental agencies get together and really come out with uniform guidelines that were available to everyone and were utilized uniformly across the country. There was guidelines published in 2013 related to dealing with food allergy in schools, but this was something that could be adopted on a state-by-state level, and this is, again, a situation where the committee felt fairly strongly that this should be uniformly applied across the country with best practices.
No, I think you covered it correctly. This is Anna Maria, that in fact, school systems, and because some of this legislation is actually by state, it's really important that that 2013 food code does get adopted by each state. There's also each state passes different laws requiring schools to stock epinephrine. So I think those are important, and we should be aware of the state that you live in and what the laws actually allow. And then, as mentioned, the CDC has a wonderful set of guidelines for early care and schools for children. And the one thing we need to keep in mind is these children age, and as they age, they carry these allergies with them potentially into college, universities, and we need to do a better job of actually having guidelines there to help young adults make better informed decisions, and for people who actually will come into contact with them to also be prepared.
Thank you.
And this next question comes from Michael Jacobson at the Center for Science and the Public Interest. Michael says, FDA and allergists generally focus on the big 8 allergens for labeling and education. Did the committee consider other allergens such as sesame, which some countries consider a major allergen?
Thank you for that question, and again, we'll refer you to the whole book that has really does address this issue. The committee does recognize, and I think was reflected in the recommendation about having a more evidence-based and country-by-country list for what the most prevalent and important health-wise allergens are. And in the process of doing that, the committee certainly recognized that there, for example, are some things on our U.S. tree nut list of allergens that are probably not public health significance here, and that there are other allergens, and as suggested, sesame seeds among them, that there is evidence to show increasing prevalence. So yes, the committee very much addressed that, and part of the goal embedded in all of these is to get the right authorities to review the evidence, both the evidence of prevalence, which we don't have perfectly yet, but also of severity. So we anticipate that with the committee's recommendations and implementation that our list of the big 8 allergens will be modified in the foreseeable future.
Our next question is from Roslyn Hosek. Roslyn asks, is there any research going on about patients with multiple food allergies, such as 8 known allergens in one person versus only 1 or 2 allergens?
Hugh, would you address that, the issue of the sort of the classic single allergen versus the clusters?
Sure. So Hugh Sampson again from New York. This is actually something that's been interesting in the evolution of the food allergy story. When I started this about 30 years ago, it was very uncommon for an individual to react to more than one food. They may have positive tests to a variety of foods, but typically would react to 1 or possibly 2. The situation today seems to be quite different in that we now see it's common to see children that have multiple food allergies. And this has certainly been an area of great interest to researchers around the world, trying to understand what has changed that we now tend to see this broader number of food allergic reactions within the same individual. There are also studies ongoing looking at various therapeutic approaches to try to deal with these multiple food allergies, which obviously put a much higher burden on the individual who now has to try to avoid multiple foods as opposed to the single food that we typically saw in the past.
Thank you. I was wondering, Steve, do you want to make any comments on that as well, the emergence of multiple allergies?
Well, I think Dr. Sampson covered it quite well. I don't know that I have anything to add. I'm certainly aware of the demographics that he mentions, that we now see, the physicians see these patients who have multiple food allergies, and so that has an impact on all of the other stakeholders, including the food industry, and certainly identifying on the labels all of these multiple foods. My one comment would be that the multiple foods that tend to be primarily the other major allergenic foods that are already recognized in the labeling regulations in the United States.
Good, thank you for that. And I think implicit in all of this is as you get to multiple allergies of common food ingredients, that the diet of the food allergy patient and the food allergy individuals can become very restrictive. And that's where one of the committee's comments about wanting to improve the quality of life and also the general health of patients. There's some nice reviews of what happens as you get more and more restrictive in the report. Thank you.
Next, we have a question from Nicole Vaughn, who's a food allergy parent. Nicole asks, how are the data by race and ethnicity in children?
Well, thank you for that question. And as you've heard as a theme of our presentation today, the data that we have on prevalence is really not very good in the U.S., even overall population. So we are even weaker and have less precise data on issues related to by age group or by race or ethnic group. That will be one of the major goals of the study that the committee is recommending to be done as soon as possible. And we would agree having information at that level is going to be important for us to make good healthcare decisions and public health recommendations.
Okay, we have time for a few more questions. Our next question is from Kimberly Yeager at Abbott Nutrition. Kimberly asks, for the food manufacturing industry, if a program such as VITAL is established, then can the reference dose be used as the target for testing equipment for allergen residue rather than chasing zero?
Very good question. I'll ask Steve to think about that because he really was our lead in thinking about the level of precision and how implementation might happen. Steve?
Yeah, this is Steve Taylor from Nebraska again. The VITAL system is underpinned by the establishment of reference doses. And while we recommended that the Food and Drug Administration should look at approaches like the VITAL system, we did not specifically endorse the reference doses that are used in the VITAL system. So I want to make that clear. We did conclude that sufficient clinical data were available that the authorities could establish reference doses. And I think establishment of those reference doses would then give clear guidance to industry on the target levels that they should use within their manufacturing facilities to protect allergic consumers. Because you would not no longer be chasing zero, you'd have a defined level to go after. And of course, all of that is predicated on having really good analytical detection methods and user knowledge of how to apply those methods appropriately to get good results. But everything at the moment is predicated on the FDA moving forward to establish some basis on how much is too much, because right now food companies are deciding that on a case-by-case basis, and it's probably quite variable between companies.
Thank you.
So we have one more question. We've gotten a lot of questions from people from various backgrounds just asking, overall, the report presents a lot of recommendations. How are we going to go from recommendations into action and make sure that the appropriate stakeholders are aware of what we're recommending?
Thank you for that. We agree that there are a lot of recommendations, and in fact, they go across really a large and varied group of stakeholders. One of the things I'll remind you of is, in fact, when we entered into this report, we had a long list of sponsors. So there are a number of groups, important groups, both on the governmental side and the non-governmental side and the advocacy side, who were very aware of the report and, in fact, are probably all with us today as we're presenting this. So I think the committee believes that we were able to identify a lot of partners. Hopefully the best partners are there, but we are very open, as will the dissemination teams, to bringing everybody in who can help with this. Now, one of the things to remind you of is that our job as an ad hoc report committee is one of simple making recommendations and being advisory both to the government and to the public. So we do not have the authority to make any of these specific recommendations. But I think if you look, one of the good things of having a report that comes out of the National Academies is it is very well regarded in general, and that in many instances it's actually been the catalyst to get things done. And I do believe our sponsors and others in the academic community will be keeping score to see what we've been able to accomplish once we all get back to our public role. So I'm optimistic about that. We know that things, different things take different time, but I really would encourage all of you who are interested in this is to work with the people that you can influence, and we have a really nice working list of things that could be done. So we hear that there are probably 700 or 800 people who've joined us for this, so I think that's a really first good step of spreading the word. And again, I'd like to thank you on behalf of the committee and turn it back to Dana.
Thank you. So that's all the time we have for questions for today. Once you exit this webinar, you will be redirected to our report page. Again, that's www.nationalacademies.org/food allergies. The slides from today's webinar are already posted on that page, and a recording of this webinar will be available next week. And with that, I'd like to thank our speakers for being here with us today, and thanks to everyone tuning in. Have a good day.